It is now my pleasure to introduce Dr. Warner Huh. Dr. Huh is the chair of the Department of Obstetrics and Gynecology and holds the Charles E. Flowers Jr. Endowed Chair in the Department of Obstetrics and Gynecology at UAB.
Well, welcome everybody. It's a tremendous honor to speak to you all, and want to welcome you to this summit. A couple things. I was at the very first summit that Isabel and I hosted a couple years ago, and one of the takeaway messages from that summit was, I'll be honest with you, I don't think that we have done a very good job listening to you all. And I think Isabel, where is Isabel? I'm not even sure. I think she would fully agree with me. And for me, it was enlightening to understand the challenges that the community faces, particularly in rural counties. And so please know that this is very much an extension of that. And so we do need your feedback because none of this works without your involvement. And but I do want to let you know from the last summit, appreciate how much you've opened up to us and shared your very personal and professional thoughts about this campaign and care for women in general in the state of Alabama. So a little bit about myself. I'm a gynecologic oncologist, the chair of the Department of OB/GYN. I've been here for over 25 years. I pretty much fully dedicated my career, entire academic and professional and clinical career to cervical cancer screening, prevention, and treatment. I dedicate much of my mentorship to really one individual, and that's Ed Partridge, who brought me to Alabama as a fellow, stayed on here, and pretty much have followed his guidance and very big shoes to fill. But for me, this is really where home lies, and deeply, deeply invested in the public health future of women in general in the state, particularly in the area of cervical cancer. Let me see, next slide. So one thing I do want to let you know is I'm going to share you a perspective that I think is unique, because as a cancer surgeon who really takes care of thousands and thousands of cervical cancer patients, these are the downstream consequences of women who have persistent HPV and abnormal PAP pre-cancer. Can share with you the perspective, not only what it is to be a cancer surgeon taking care of these patients, but also what the front-end screening and prevention very much looks like. Before I get into that, I would be remiss to say that I want to thank, obviously, Rotary Birmingham, Rotary International, obviously the Alabama Department of Health, Scott Harris. I want a huge shout out to Nancy Wright, because if it were not for Nancy, none of this would have actually gotten off the ground. Obviously, want to recognize Gary Pugh, who I've known for many, many years, but also Quality Life Health Services, Together for Her, and then the American Cancer Society. There are a bunch of other people, but they deserve really the lion's share of credit for getting this off the ground. Okay, so I'm going to share you a perspective. You're going to hear a lot of information that may come as a surprise to you all, and you're going to get a little bit of a history lesson as well. So you're going to get a little bit of everything. So in the state of Alabama, we rank 7th in terms of cervical cancer incidence in the United States and 3rd in mortality. So we still have a very long way to go. And this is actually the fundamental driver for why we have Operation Wipeout. So back in the 90s, the National Cancer Institute put out a document discussing what the gaps of screening were. Remember, this is in 1998, about how many women in this country who were diagnosed with cervical cancer were either underscreened or unscreened. And that number is quoted to be about 60 to 65%. So the majority of women who develop cervical cancer have not been screened at all, or they've not been screened appropriately. So Vicki Bernard, who works at the CDC, and I and others looked at a basically registry-based study looking at women who were diagnosed with cervical cancer in 4 different states, and looked back and tried to figure out how many of those women who actually got cervical cancer were screened appropriately or underscreened, because we wanted to know literally 25 years later where we stood. And interestingly, still to this day, more than half of the women in this country who develop cervical cancer are still unscreened or underscreened. All right. So this is not the takeaway message I want you to leave with the room, but I do want you to know this, because this is actually factually accurate. If we screened and treated perfectly in this country, we would actually not need the cervical cancer vaccine. That is the power of screening and treatment. The vaccine adds an additional layer of protection, literally, but realize as a country, we have not made that much of a dent, unfortunately, in terms of making sure that we screen individuals appropriately against cervical cancer. So, this is going to be my 5-minute history lesson to you all, which I think is really relevant to this. And Isabel has seen this many, many times. You probably know who this person is just by name. Okay. So, this is George Papanikolaou, who famously has the PAP test named after him. And briefly, I think it's a really cool story. And actually, there's a UAB faculty member that wrote a great biography by Dr. Papanikolaou. Grew up in Greece, got his PhD in Germany, came over to the United States to New York to seek work with his wife, Mary Papanikolaou. He, for those of you that have grayer hair like me, probably remember the department store Gimbel's in New York City. I'm originally from New York City, so I know this department store well. He sold rugs during the day, at night, played the violin at night at restaurants to make sure that he could make ends meet. And he landed a job as a lab tech at Weill Medical College at Cornell University looking at the menstrual cycle of guinea pigs. Okay. So, I mean, without getting into detail, we don't have these fancy hormonal assays back in the 40s and 50s like we do now. So, we had to use different tests to figure out what two phases an animal like a guinea pig was in the menstrual cycle. But the only problem is a guinea pig, they don't menstruate, they don't have a period. So, you can't figure that out. So, he used sort of his discovery in guinea pigs and extrapolated to women. And that is the genuine, basically, genesis for the PAP test that led to this seminal article that was published in one of our major journals in August of 1941 that basically looked at the value of using a PAP as a screening test. And then after that, essentially after World War II, the rest is history. We introduced mass screening to this country, and basically we saw cervical cancer rates plummet by at least 70%. Keep in mind that in the 1930s and 40s, before this was introduced, the incidence of cervical cancer was at least twice of that of breast cancer. And breast cancer is by far the most common malignancy that we deal with in women. So this definitely speaks to the power of screening. And every screening test that we have in the cancer realm is indexed against what we've learned on the PAP test. But who's the individual that doesn't get credit in my view? That person is actually his wife, Mary Papanikolaou, who's winning the Medal of Freedom from the King of Greece at this time. So she's famous for three things. All three things are true. I've validated this multiple times. One, she is the first woman in history to undergo a PAP. Okay, not surprisingly. Number two, she's the world's first cytotechnician. And then three, as her dedication to the cancer prevention world and women's health, she actually underwent a PAP every day for 20 straight years to understand how that PAP test would change with her husband. And the biggest shame is neither one of them was recognized for the Nobel Prize. But I will speak to you that this is probably the world's greatest screening achievement, cancer and otherwise, known to man today, and women for that matter. So I just want you to recognize the amount of gratitude that we have to this pair in terms of how we look at all cancer screening. So where do we stand in the state of Alabama? Well, the challenges that we have is that we know that there are significant racial disparities in terms of outcome, whether it's incidence and particularly mortality. And as you can see in this slide here, we know that Black women are more likely to die from their cancer than their white counterparts. This is not fully explained by the lack or access to screening. There are other factors that are involved with this, but we have to do a better job normalizing a state that is at least 30% Black in terms of making sure that we don't have these disparities in outcomes in our citizens of the state of Alabama. So this was shared with me by Isabel, but this kind of gives you an idea of both the mortality rate, the late stage percentage, as well as the incidence rate. Incidence is defined as new cases per year in the state of Alabama. Red is bad, yellow is sort of middle ground, and green is better, so to speak. And you can kind of see that the counties in red are those rural counties that you could argue that have lack of access to care, and we need to do a better job at this. But one thing I think you're going to hear that is fascinating to me. So if you can see on the far right panel, this is the incidence, the new case rate. We've done a lot of work, as Isabel mentioned in the video, with Chambers County. So Chambers County, which is in the far right, it's the only one on the right-hand side, right border, eastern border of the state, it borders Lee County, which is, as many of you all know, is where Auburn University is, right? They share a major border, yet the incidence of cancer between these two counties is strikingly different. And in fact, I think Isabel will probably talk about this a little bit, but it speaks to a lot of socioeconomic variables that we deal with in terms of this particular type of cancer. But what is striking is that you can get so much on the micro level per county in terms of incidence and outcome, including mortality, as it relates to cervical cancer. So I just wanted to get for you all to have a general idea of kind of where we are today. And so we have a long way to go. So a couple facts I think you need to take away and put in your back pocket or in your head is one is the overwhelming majority of cervical cancers are caused by HPV. And I'm just going to get into this in a second. It's not that one-time infection that the women get. It's a persistent HPV infection over time. The second thing is that, HPV is extremely common in women. At any point, approximately 20 to 30 million in this country, million women in this country are positive for HPV. That number is probably a lot lower with HPV vaccination. But what we know through work through the NCI and other groups internationally is that if a woman gets HPV, there's at least a 90% chance, 9 out of 10 chance, that that individual woman will clear the virus on their own. Okay. So I will get up and I will editorialize this because I think it's really important. But in the early 2000s, specifically 2006, when the first HPV vaccine was approved, I think we approached this the exact wrong way. And we scared thousands, if not millions of women thinking that because they have HPV, they're going to get cancer. Okay. It's not that simplistic. They have to have a persistent infection, usually with the same type over time. So these are three things I think you guys have to recognize as it relates biologically, that link between HPV and cervical cancer. So there's been a lot of research in this area, but what I want to explain to you all is one piece is acquisition. The other piece is persistence, as I mentioned. 90% of women will clear their virus over time. And it's the progression of that persistent infection to precancer and then cancer that is the real risk factor for developing cervical cancer. So why do pap smears, HPV tests work in this country, in the United States? They work because we can intervene earlier before the individual patient or woman gets cancer. That's why pap tests have worked as well as they have over the last 60 or 70 years. So this is sort of the general paradigm from how women go on from HPV infection all the way over to cervical cancer. And this is exactly the reason why HPV vaccination and testing are critical to not just this presentation, but to Operational Wipeout. And again, this is Mark Shipman and Phil Castle are two preeminent experts at the National Cancer Institute, dedicate their entire careers to understanding the biology of HPV and cervical cancer prevention. Again, this kind of schematically kind of shows you how this works. Okay. So most women will get HPV when they become sexually active. So there's a huge spike. And then that incidence drops as an individual woman gets older because they're spontaneously clearing it. Now, as more individuals get vaccinated, that drops even faster, basically, right? And what we'll know, and you'll see a subsequent slide, is that if you're vaccinated as a girl, your risk of getting this is actually zero. That's how effective the vaccine is. The data is astounding, but this kind of gives you an idea of the general progression and the general promise of cervical cancer prevention. So what we obviously want to espouse, and you've heard this before, is we want to get people vaccinated, okay? And, the vaccine, which has been around 2006, the one that we use in the United States is the second generation version of the vaccine, is extraordinarily effective. But what you'll hear is extraordinarily safe. It's one of the most scrutinized vaccines, not in the US, but for the world. But it's more importantly, its efficacy is really unbelievable. But we got to vaccinate the right cohort, particularly girls and boys between 11 and 12 years of age. So at one point, we had to give everyone 3 doses. Now we can actually get down to 2 doses up to about 14 years of age. And after 14, people can still get vaccinated up to 26. Actually, technically, the vaccine is approved up to 45 years of age in this country. But after basically 14, you need to get 3 doses. What's fascinating, and this kind of aligns with the whole polio discussion as well, is that we may get to a point where there only one dose is actually sufficient, right? And there's been work in this area internationally to understand whether one dose is sufficient to achieve protection. So what are the other additional benefits? Obviously, today we're talking about cervical cancer, right? But there are other malignancies that are attributed directly to cervical cancer, and the biggest one is probably oropharyngeal cancer. In fact, a couple years ago, the incidence lines between cervical cancer and oropharyngeal cancer have officially crossed, whereby oropharyngeal cancer is the more common HPV-related malignancy than cervical cancer, obviously because they affect both men and women. Obviously, women only have a cervix, but the bulk of disease, as you can see on this slide, actually occurs in women and women alone. Okay. But the question comes up all the time, why should we vaccinate boys and men? Well, this is the reason. This is the biologic reason for why you should vaccinate boys and men, because there's a known entity disease in that cohort that's important to protect as well. And coming off basically the COVID vaccine, I think people now generally understand the concept of herd immunity. It's important to vaccinate the entire population and not just a segment, basically. So, for those two reasons alone, that's why we vaccinate both men and women, boys and girls equally. So, again, a couple things I want to just highlight. One is that we want to make sure that everyone is getting full dose. Frankly, and please don't quote me on this, I would just be happy if women and boys and girls got just one dose, right? Particularly at a young age, but we want to make sure that they get the full series. The data is overwhelmingly in support of the vaccine and demonstrates near almost 100% efficacy. As I mentioned, it's extremely safe. We have a registry that looks at side effects for all vaccines, including the HPV vaccine through the FDA, that's monitored carefully. And I can just tell you, after millions and millions of doses that have been given internationally, I can honestly say that it's an extraordinarily safe vaccine. And you hear a lot of things. You hear things like, oh, it causes Guillain-Barré syndrome. It causes premature ovarian failure. And I'm happy to get into that later, either in this group or individually, how to look at that data. But it's been highly scrutinized. What are the main side effects? Obviously, you're going to get some arm pain from the shot. You also most people have to sit down for a couple minutes, because we had some cases early on where boys and girls particularly were getting vaccinated and they would pass out and hit themselves in the head. So that's why if you actually look at the label, that we will actually want them to sit down for a period of time before they leave. So mainly the main issue is really arm pain. And the cost issue. This was a big issue in the 2000s and 2010s. I think we have covered this through the Vaccines for Children program, but the cost has been largely addressed. And I would say that this is much less of a barrier now in 2025 than it certainly was 10 years ago. So screening. So the screening in this country, and I'm not going to lie to you, this is kind of all over the place now, is between 21 and 65 years of age. At the minimum, we want people to be screened every 3 years. We're not living in an era where we screen yearly, and many people in the room probably remember that, your gynecologist said get a pap every year. We don't do that anymore, and we try to screen every 3 years. We have recommendations that extend screening out to every 5 years. I will tell you personally, I think it's too long. I can't remember what I did healthcare wise 5 years ago. So why should I expect my patients to remember what they did 5 years ago? But the screening interval is generally set at every 3 years. And we use both HPV as well as pap cytology. So this is data from the UK and Scotland, particularly, that looked at what's the rate of invasive cancer following after the administration of a different type of vaccine that's given in the EU and the UK. And the bottom line is that there were no invasive cancer cases in women that were vaccinated at the ages of 12 or 13, which is the target age in this country as well for the most part. All right. So again, a lot of this was sort of scientific in terms of, oh, does the vaccine work or not? We have compelling population-based data, whether it's from the UK, from Australia, New Zealand, from the Netherlands, that show overwhelming efficacy and protection related to this vaccine. I mean, I will tell you, this is a true story. I have a bet with a colleague of mine that by the time I retire, which may be about 10 years from now, I actually believe that we will stop screening women altogether in this country because the vaccine is so effective. Okay. We just got to get to that threshold. So I really don't want to lose the bet, guys. Okay. So that's why this is important. But anyway, but I just wanted to show you from a population based level how effective the vaccine is. So, what are we doing for screening? Obviously, you know about the cervical cytology, the pap test. We're using a lot more HPV testing, not enough, in my opinion, in this country. But I will tell you right now, HPV testing is a much, much, much better test as a screening test than pap cytology. And it will be going forward. And I think the reasons are beyond the scope of this presentation. But we do a lot of bit of both. What's exciting is the FDA has recently approved what we call self-collection. And so what this is, a woman can actually take a swab and insert it into the vaginal area instead of having to go undergo a speculum exam, a formal pap, a pelvic exam. And that has been an FDA-approved mechanism to screen. The next wave to that is to take self-collection and allow the patient to screen at home, right? So right now, self-collection is only approved in the clinical setting, but you can probably think about how much of a game changer would be in our state, particularly if we can get women to at least screen at home, and it would allow us to consolidate our resources and identify women at greatest risk to come in and get evaluated or treated. So a lot more to come on the topic of self collection. And some of you may have read this in the New York Times or the Wall Street Journal. So in understanding screening results, a lot of sort of emotion here that I think is important. One is that a positive screening test does not mean that a patient has cancer. In fact, more often than not, it does not mean that they have cancer. But if this makes sense to you all, we can screen as much as we want in this state. But if you don't have a mechanism to follow the abnormalities and evaluate and treat them, screening is absolutely useless. Okay. So, like as I say to my kids, when you pass the salt, you usually pass the salt and pepper together, right? So the two of them are interlinked. If you want an effective screening program, and there has to be an effective evaluation and treatment program. And that's where people like Gary Pugh and the Alabama Department of Public Health have been transformative in making sure that we improve access to evaluation and treatment in this state. That is absolutely critical for this to be successful going forward. So I'm going to step back. I'm going to make some comments here. Please know that when I speak from a purely scientific perspective. There's no political agenda here. I want to make sure you understand that. But I do want to put something into perspective. And I think Scott Harris and the Alabama Department of Public Health would fully resonate with this. Okay. I know that there's been a lot of discussion about vaccine, particularly in Congress, in the media, on social media, et cetera. But I do want to put something into perspective that I think is really important for this group. How many of you all have seen a case of smallpox? None of you should have, right? Because it is the one disease that has been completely eradicated from the face of this earth by what mechanism? By vaccination. Okay. And you have to understand that more people died from smallpox in the 17th, 18th, and 19th century than cancer and cardiovascular diseases combined. Okay. So this really speaks to the power of vaccination and how important this is. And I think that it's really kind of important to recognize this. So of all the slides that I present, I think this is probably the most important slide. So yes, I think we probably have way too many vaccines in the market, but realize that in 1900, more people in this country, the United States, died from the diseases that are listed on this slide compared to cancer and cardiovascular disease combined easily. Okay. Now, these are all diseases that we vaccinate our children against. And what you may not realize is that when you vaccinate your children, you're actually not just helping your child, you're actually helping your community. Okay, this is actually an essential concept. It's the first major public health act that that a citizen of this country provides to their community by get vaccinated. You can see what the cases are pre-vaccine and the cases post-vaccine. It is not. It is more than just dramatic, everybody, about the importance of vaccines. So we also need to put in perspective, not to throw the baby out with the bathwater, and recognize that a lot of this is out of sight, out of mind, and that vaccines unquestionably have done two things to the population in the U.S. and internationally. One, extended life, and markedly improve the quality of life over the overwhelming majority of people. But it's a community effort. It's not an individual basis in terms of how vaccination programs work in the United States internationally. So I just wanted to show this to you for why this is important to discuss, particularly now, purely from a scientific level. So again, I think you all know that the World Health Organization had put out a campaign several years ago to eliminate cervical cancer through screening, vaccination, treatment, quality of life, contemporary oncology care. And we can do the exact same thing with HPV and cervical cancer. When you hear the comments in the video that people say that we can eradicate this, that is not hyperbole. That is like literally, we can take down the incidence of cases to literally less than 500, 100 cases if done correctly. It's hard, but we have all the tools to do this. And I just, for a fact, I actually had one of the greatest things I did in my career is I had the opportunity to present to the UN about 10 years ago before the campaign, which is the bottom left, to talk about the importance of vaccination screening, not just at the US, Alabama level, but really at the international level. And I think this is very, very much achievable. So again, it just takes 3 easy steps. One is promote the vaccine. It's really important. You got to give the vaccine before the sexual debut of our teenagers. That's when it works best. Two is that we got to promote screening, right? Promote screening, and we'll take our job with the Alabama Department of Health is to make sure we have access to evaluation and treatment. Okay, so that's the deal that we will make. And so going forward, you need all 3 pieces to do this effectively as a wipeout campaign. But again, this is all achievable. So I appreciate it. I don't know if you want me to take questions, Isabel. I'll be happy to take a couple questions, but truly an honor to present this to everybody. Thank you.